Hello again, EMT student. My name again is Paul Bedell, one of the adjunct faculty here at Pima Community College. I'll be covering chapter 12, which is shock today. As I've said before in previous lectures, please feel free to take the notes. That way, when you get back to class, that first hour we'll be covering any Q&A information that you might have had from any of these lectures from this month. All right, go ahead and get started with this. All right, so shock or hyperperfusion describes a state of collapse and failure of the cardiovascular system. Early on stages of shock, the body attempts to try to maintain homeostasis, which is a nice balance in the body's systems. Wants to keep everything in check. So that's how the body starts to compensate for this. And then as shock progresses without any treatments or any rendering of any aid, that blood circulation slows and eventually ceases. So starting from a cellular level, things start to die off. Shock can also occur because of medical or traumatic events. That's the two most common reasons why someone's going to be going into shock. So you as an EMT are going to respond to different types of emergencies to provide care and transport of that specific customer or patient. They must be consistently alert to the signs and symptoms of shock. We're going to be discussing those signs and symptoms of shock and how to treat it. So adequate perfusion. This is normally what the body should be doing, right? It's required to provide the cells the oxygen, nutrients, and get rid of the waste products that the body's already utilized and doesn't need anymore. Body is perfused via the circulatory system, which is a complex arrangement of all the connective tubes, like basically plumbing. And that includes all the arteries, arterioles, capillaries, venules, and even veins as it goes to and from the heart, to and from the lungs, and of course, to and from systemically throughout the body. Two circuits in the body: systemic circulation, as I said, throughout the body, and pulmonary circulation, which is going to get reoxygenated in the lungs. So systemic circulation carries that oxygen-rich blood from the left ventricle, that's the medial buffer part of the heart, and it's going to pump it throughout the body. Eventually, as it goes throughout the body, where it gets the oxygen transported to all the cells, eventually it gets used up, and it's going to venture right back to the heart, right into that right atrium. As the blood passes through the tissues and organs, again, it's going to deliver the oxygen, as I said, nutrients, the energy, everything those cells need to survive. Organs, tissues, and cells must have adequate oxygenation, or else they will start dying off. So what about pulmonary circulation? Pulmonary circulation carries that oxygen-poor blood from the right ventricle to the lungs, and then as it gets reoxygenated at that alveolar sacs, eventually it will return back to that left atrium. Each time you take a breath, the alveoli, which are microscopic thin-walled air sacs, receive a supply of oxygen-rich air. Oxygen diffuses through the walls of the alveolar into the bloodstream and attaches to the hemoglobin so it can be transported, and that hemoglobin circulating on the red blood cells. That's how it gets to and from their destinations. Diffusion is that passive process in which the molecules move from an area of higher concentration of molecules to an area of lower concentration. So as you breathe in, take in the oxygen that you need, that high level of oxygenation is going to diffuse with the higher levels of CO2 that's already in the bloodstream, waiting to be diffused and exhaled out of the body. Oxygen molecules, again, move from the alveoli into the blood, and the carbon dioxide moves out. So again, that waste product can be removed from the body. So whereas the majority of oxygen is carried to the tissue attached to the hemoglobin, carbon dioxide can be transported in the blood from tissues back to the lungs in three ways: dissolved in the plasma, combined with water in the form of bicarbonate, and attached to the hemoglobin, as it was with the oxygen attaching to the hemoglobin. So carbon dioxide waste products released from the cells can combine with that water in the bloodstream, form one of these options was the bicarbonate. Bicarbonate concentrations becomes higher as more carbon dioxide is produced. Makes sense. More carbon dioxide is produced, the higher the number, hypercarbic you start becoming. And again, that blood will move back towards lungs for reoxygenation. Once it does reach the lungs, the bicarbonate breaks down into carbon dioxide and water, and the carbon dioxide is exhaled. That should be done without any thought process to you whatsoever. So in cases of poor perfusion, transportation of carbon dioxide out of the tissues is impaired. You're going to start to retain that carbon dioxide levels, and that's where you start to become hypercarbic. That results, again, in which those may cause cellular damage and eventually death to those particular cells. So shock refers to a state of collapse and failure of the cardiovascular system that leads to inadequate circulation or perfusion. Shock is an unseen life threat caused by medical disorder or traumatic injury, as we said earlier on. To protect the vital organs, the body directs the blood flow from the organs that are more tolerant to low flow to organs that can't tolerate low blood flow. If the condition causes shock or are not promptly addressed, death can soon occur. So 3 things the cardiovascular system is going to contain: the heart, or the pump itself, the set of pipes, blood vessels, and then of course the blood itself. The heart is basically an electrical mechanical pump, but it needs these components to be able to function appropriately. So this quick picture from the book just shows you a kind of a diagram of how, of course, the anatomy, all the different parts. And if you can think of the drop of blood and how it passes through all these particular parts, you can see that if we mentioned how the blood goes from that left ventricle, see how much meatier and buffer it is, that's going to be able to pump blood out from that left ventricle through the ascending and eventually descending aorta, so up to the carotids, of course, all the way to the brain, and then eventually systemically all the way down to every single finger and toe. Once it's been utilized, all into the cell beds and all that diffusion's taking place, eventually that CO2 now is the higher number that's in that bloodstream, so it wants to venture back for eventually exhalation. So as it ventures back to the heart, it's going to venture back eventually through the superior inferior vena cava or vena cava. And then as it enters into that right atrium, going into eventually that right ventricle, and then up through the pulmonic valve, already across to both pulmonary systems, right, the lungs, and through the pulmonary arteries, arterioles, eventually the capillaries, and as it ventures back through the venules to the veins, back into that left atrium, and so forth. That's just a brief synopsis of that, of course. Other chapters, we're going to cover more in detail of the drop of blood and how it passes through every specific chamber, every specific valve, but just wanted to cover that real quick. So these are the 3 parts that can be referred to as the perfusion triangle. These 3 components, of course, need to be there and functioning appropriately for circulation to, of course, take place. We already mentioned the heart, the blood vessels, and the blood itself need to be there. So what about blood pressure? That's going to be the pressure of the blood within the vessel walls at any moment in time. Systolic is the peak arterial pressure. When you're checking someone's blood pressure and you're setting the stethoscope at the antecubical region of the arm, you're trying to listen for that lub-dub. Okay, so as you inflate the blood pressure cuff, eventually it's going to become like a tourniquet, so you won't be able to hear anything, right? And then once you deflate that cuff, once you start to hear that first lub-dub, that's when you want to mark the number that's on that blood pressure cuff to note what their systolic number is. And then eventually you won't be able to hear it anymore because it's going to become quieter and quieter. And as you stop hearing that last lub-dub, you mark the number for the diastolic number, where's that rest. How about pulse pressure? That's going to be the difference between the systolic and diastolic. We're going to mention at some point about narrowing pulse pressures. There also could be something for widens the pulse pressures. When we refer to pulse pressures, we're talking about the difference between the systolic and diastolic numbers. So again, pulse pressure signifies the amount of force that the heart generates with each contraction or beat. And a pulse pressure less than 25 millimeters of mercury may be seen in patients with shock. Blood flow to the capillary beds is regulated by the capillary sphincters. These sphincters, again, along the capillary beds and all the blood vessels, they're going to be what the blood has to pass by. And again, those sphincters are supposed to allow for that constant motion in that one direction. That's under control from the autonomic nervous system. And these sphincters respond to other stimuli. It's hot, cold, and your body's trying to regulate that type of temperature, right? The need for oxygen and get rid of the waste products that we don't need anymore, like high levels of CO2. Perfusion requires more than just having working cardiovascular system. It also has to have working respiratory system. They got to work in conjunction with each other. So you got to have adequate oxygenation to exchange in the lungs for that diffusion to take place, so the oxygen can be replenished and the CO2 can be get rid of it. Adequate nutrients to form the glucose in the blood. Eventually that's going to get to those cells, because the cells need the oxygenation. It needs the nutrients to continue to survive. And adequate waste removal, right? We got to get the waste removal. We cannot retain high levels of CO2. We cannot retain any of the toxic waste that's maybe in the bloodstream. We have to be able to get rid of that so our body maintains that nice homeostasis. Some of the mechanisms are in place to support the respiratory and cardiovascular systems when the need for perfusion or vital organs is increased. The mechanisms include the autonomic nervous system and hormones, like epinephrine. Hormones are triggered when the body senses pressures falling. This can cause an increase in your heart rate. Your heart rate, you start feeling it getting faster and faster and faster as something is triggering because of your body is trying to compensate for a traumatic or medical situation. Strength of cardiac contraction. Your heart's going to have to work harder, push that blood through those blood vessels. Peripheral vasal constriction. So again, blood vessels constricting or blood vessels dilating. For constricting, they're going to get smaller. So the heart's going to have to work harder to push through those smaller openings, which is increasing pressure. So we mentioned like a garden hose. Same amount of volume coming out of the garden hose goes a certain distance. Cover your thumb over the garden hose to make the opening smaller, and you're going to increase that pressure to go further distance. So together, these actions are designed to maintain pressure in the system. So it's pumping blood through the areas necessary. Probably not going to go all the way down to the pedal areas, right, in the feet. You may get some weak distal pulses, but it may want to shunt or try to reroute that blood to the core organs, like the brain, heart, and of course, lungs. And those being the vital organs, of course. And it is the response that causes all the signs and symptoms of shock. So shock can result from bleeding, respiratory insufficiency or respiratory failure, an acute allergic reaction, overwhelming infection. We're going to talk about the different types of shock here in a little bit. And that damage occurs because of insufficient perfusion of organs and tissue. So what about the pump itself, the heart? It fails, right? Some type of traumatic event or something medical in nature from chronic or acute condition. The blood volume from either bleeding out, or maybe you're vomiting, diarrhea, an excessive amount of fluid loss, you become hypovolemic. How about poor vessel function? Either the vessels become all thickened and plaque build up, right? Or they become weak and hardened walls where they may leak or rupture that way. These are just the types of shock in conjunction with a type of cause like pump failure, poor vessel function, and low fluid volume. Again, this is in chapter 12, table 1 here. So these are the types of shocks that we're going to cover here in just in a second. All right, first one being cardiogenic shock, caused by inadequate function of the heart. Makes sense, right? Cardiogenic, cardiology, heart. Easy to remember, right? Major effect is the backup of blood into the lungs. That's where the patients are going to exhibit some difficulty breathing, shortness of breath. You may even hear fluid building up, usually lower lobes because of course gravity, starting down low, eventually building up and it continues to fill up with blood. So here's an example of cardiogenic shock when it comes to down into the alveolar sacs, where that fluid starts building up. With fluid building up, again, aside from all the signs and symptoms they may be exhibiting, but also diffusion may not be very effective or efficient because of the fluid that's in the way. Pulmonary edema leads to impaired respirations. Because again, you have fluid in the pulmonary region. We're not meant to breathe underwater. And that can be increased respiratory rate. You're trying to breathe more to get the oxygen in that's necessary to survive, but it's just not working as well, right? And then again, those abnormal lung sounds or just crackly, You may hear that fluid in the lower lobes. So listen all around that chest area to see where you can find that fluid building up. And this cardiogenic shock will develop when the heart can't maintain sufficient cardiac output to meet the demands of the body. Cardiac output is the volume of blood that the heart can pump per minute, and it's dependent upon heart must maintain or must have adequate strength to be able to perfuse adequately for that distance that it's going to go systemically, which is largely determined by the ability of the heart muscle to contract. The heart muscle contracting, it's going to need that electrical impulse. Remember I was saying electrical mechanical pump, right? Heart must receive adequate blood to pump. It's got to have blood in the chamber to pump, otherwise it's not pumping anything. And that resistance to flow in the peripheral circulation must be appropriate. You've got to have that low pressure, high pressure in the specific chambers of the heart. How about obstructive shock? Thinking about an obstruction, right? Caused by mechanical obstruction that prevents an adequate volume of blood from filling the heart's chambers. Three of the most common examples: cardiac tamponade. We'll talk about that one later. Same thing with tension pneumothorax we'll talk about. And we've kind of already mentioned about pulmonary embolism, being a blockage in somewhere in that pulmonary region, right? So cardiac tamponade, collection of fluid between the pericardial sac, so that lining around the heart muscle itself, and the heart, the myocardium. And that basically is the effusion, which is that fluid around that lining. It becomes large enough to prevent the ventricles from filling with blood. So with every contraction of the heart, every time that heart wants to contract, that fluid's going to increase and it won't be able to refill back up to that normal position again. And it gets worse and worse with every beat. Continued pressure within the pericardial sac again obstructs the blood flow into the heart, resulting in decreased output or outflow, right, to the rest of the body. And this could be caused by blunt penetrating trauma, and it could be some medical condition over a period of time. Some of the signs and symptoms, what are you going to see from this patient? What are they going to be kind of telling you, right? We're going to have something here referred to Beck's triad, and this is going to be JVD, right? Jugular vein distension. And the jugular veins, they'll be bulging out, basically, from the fluid or blood backing up into that region. The heart, as you're listening to the heart, it may make some muffled sounds and narrowing pulse pressures. So again, remember what narrowing pulse pressures means. It doesn't really refer to the pulse, it's referring to that blood pressure check, right? And how the systolic and diastolic become closer and closer together. What about tension pneumothorax? Damage again to the lung tissue. Air normally held within the lungs escapes, not the normal way, of course. It escapes into that chest cavity, putting pressure onto that either one or both of those lobes. The lung collapses and air applies pressure to that organ, including the heart and the great vessels. So let's say we have an example of one side here. The lung is damaged in some capacity and the air is leaking out into that cavity, putting pressure on that lung. So with every breath you take, that lung wants to expand to its full capacity, but it can't because now there's pressure being exerted against it, right? So eventually that heart or that lung will get so much pressure against it and collapse, it's going to push against the heart, right? Mediastinum, the great vessels here, and it wants to push against that, where it eventually, of course, it can cause damage to the heart, cause it to start failing, and then we're having serious problems there, right? And then pulmonary embolism, the blood clot, blocking flow somewhere in that pulmonary region, the pulmonary vessels. Eventually, these pipes from arterioles to arteries to arterioles to the capillaries back to the venules, veins. Well, eventually, these blood vessels at some point get smaller. Well, that embolism is going to travel through to a point where it's wedged, right? It can't go any further because of the size of the piping. So if massive, can result in complete backup of blood into the right ventricle, and then leads to catastrophic obstructive shock, which of course pump failure, which of course would lead to death. Distributive shock results from widespread dilation of small arterioles and small venules. These are going to be the smaller blood vessels. They become dilated, okay? The circulating blood volume pools in these expanded vascular beds. Because they're so large now, as the blood is still, the same amount of blood should be traveling through here, right? We're not talking about hypovolemic or hemorrhagic issues. That same amount of blood is traveling through these blood vessels that have now gotten so big, they're just lying and pooling in these little areas and not circulating throughout the rest of the body. wherever it needs to go. And then this tissue perfusion again starts to decrease. Now, septic shock, septic, infection, sickness. Everyone remembers septic shock as part of a distributive shock. It occurs as a result of a severe infection in which toxins are generated by bacteria or by infected body tissue. These toxins damage the vessel walls, causing increased cellular permeability. It starts to leak, right, and break down. And we don't want that blood to go anywhere else but where it's supposed to go. The widespread dilation of the vessels in combination with plasma loss through the vessel walls result in that type of shock, which again, the body starts compensating for, then eventually it starts to decompensate. So it's a complex problem, septic shock. There's insufficient volume of fluid in the container, okay, because much of that plasma has leaked out of the vascular system, where we get the hypovolemic issue. The fluid that has leaked out often collects in the respiratory system. You're interfering with the respiratory system, right? You're interfering with how I'm breathing. The vasodilation leads to a larger than normal vascular bed to contain the smaller than normal volume. So we mentioned earlier about vasodilation, how it's going to pool there. Well, now we've reduced also the fluid volume. So now they're really pooling in these areas. Now we almost have no perfusion at all because of the amount of volume that we've already lost. All right, another form of distributive shock is neurogenic shock. Neurologically, thinking of central nervous system. Usually a result of a high spinal cord injury. Some causes include brain conditions, tumors, pressure on the spinal cord, or even spina bifida, which is something at birth effect, which the pediatric chapter didn't cover that again. So muscles in the blood vessel walls are cut off from the nerve impulses that cause them to contract. So there's no communication there telling it what to do. All vessels below level of the spinal injury will dilate widely, increasing the size of capacity of the vascular system and causing that blood to pool. Same thing we mentioned earlier about the blood vessels dilating, and it starts sitting in those low-lying areas and not perfusing adequately. So the available, we'll say 6 liters of blood in the body can no longer fill enlarged vascular system. Even if there is no blood or fluid loss, perfusion of the organs and tissues becomes inadequate and shock will occur. So we don't have to have a hypovolemic issue for this to happen. And then signs are absence of sweating below the level of the injury, normal and low heart rate in the presence of hypotension, right, low blood pressure, and normal to even warm skin. It's still good to get an actual, of course, body temp. Okay, anaphylactic shock, again, another form of distributive shock, occurs when a person reacts violently to a substance to which he or she has been sensitized to. This is way beyond a little bit of an allergy, right? A little seasonal thing. This is an anaphylactic issue leading into shock if not, again, treated. They become sensitive to a substance that did not initially cause the reaction. Over time, eventually, I may build a shellfish allergy or something like that. Over time, getting stung by a bee, and now all of a sudden I have a reaction. Next time I get stung, it could be worse. Each subsequent exposure again tends to produce a more severe reaction, and this is pretty common in most situations. You'll see as your body starts to react to, again, it doesn't have to be environmental things in that sense. It could be changes in laundry detergent, whatever it may be. You start building up to being sensitized to it, and your body starts to react to it to kind of get rid of it. It's an enemy of the body, right? We want to be able to react to that. So 4 categories of exposure include injections, right? Something got injected or entered into the body through an injection site. Stings from either some type of wasp, bees, whatever it may be. You ingested it, you ate it, right? Medications, foods, drinks, whatever it may be. Or you inhaled it, like pollen or whatever it may be, like seasonal stuff. This is something you inhaled, pet dander, whatever it may be, that causes you to have a really bad reaction. This can develop within minutes or even seconds, depending on, again, the concentration, health of the person, a variety of factors there. Second phase reaction can occur 1 to 8 hours after that initial reaction. The signs are very distinct when it comes to anaphylactic shock. Thinking of respiratory issues, starting to get tightness in the chest, The bronchioles, airway starts to constrict and get really small and small and small. And then as they start getting small, of course, I'm not getting in the oxygen as much as I used to. So expect me to start turning a little blue, right? That's usually a bit of a late sign. It starts out with like blue lips, and eventually you get the blue skin in the facial area. And then it's going to get worse and worse before you stop breathing altogether. So again, some of the signs and symptoms. So system being the skin, circulatory system, respiratory system, and some others, and what these signs and symptoms would look like, okay? And it's gonna vary, of course, per patient. You may not see someone hit all these bullet points here, of course, like they're a textbook anaphylactic patient, but just make sure you go through this second table here in chapter 12 and see what those differences in those signs and symptoms are with every specific body system that that patient has. Of course, it's always good to ask the patient too about, hey, what was it that you ate, drank? Did something poke you, sting you, bite you, whatever that may be, a plant or insect or something, right? Gotta do our investigative questions. All right, again, another form of distributive shock is psychogenic shock. Sudden reaction of the nervous system, still affecting that central nervous system, just in a different way. Produces temporary, generalized vasodilation. We're pretty confident about what these blood vessels are doing during distributive shock, right? We're dilating those blood vessels, and eventually I might even pass out or, go unconscious from it. Could result in a syncopal episode or a fainting episode, right? Or I just feel faint, lightheaded, dizzy. And eventually, if you don't sit me down, I'm gonna fall down. And then some causes are serious and others aren't so serious. But we still need to figure out what happened, what caused this, right? Get into your questions and answers, right, with the patient. Do your thorough assessment. Examine the body, find out what's going on. Was there any traumatic cause, or was there any medical cause of this, right? We still gotta do our assessment. And lastly, would be for psychogenic shock, would be life-threatening causes include irregular heartbeats. Even a brain aneurysm could be one of the causes. Non-life-threatening events include receipt of bad news, experiencing fear, unpleasant sights, sounds, smells, tastes, whatever it may be. But that could be a non-life-threatening event, but still cause some type of a fainting episode, lightheaded, dizzy, whatever it may be, right? All right, so now we're gonna go into hypovolemic shock. This is a result of inadequate amount of fluid or volume in the circulatory system. We talked about hypovolemic shock already, so it should be pretty straightforward here. A hemorrhagic cause, right, some type of bleeding, or non-hemorrhagic, which would be still a volume issue. I mentioned about diarrhea, vomiting, you become dehydrated. That could be a form of non-hemorrhagic. This occurs with severe thermal burns. Intravascular plasma is lost. The plasma leaks from the circulatory system and into the burned tissue that lies adjacent to those injured areas. Dehydration, loss of water or fluid from the body tissues can cause this type of shock, as I said earlier. Fluid loss may result from vomiting, diarrhea, even excessive sweating, whatever it is, from hyperthermic issues, being out in the sun so much, and you're getting dehydrated, not replacing that fluid loss. You could go into the form of hypovolemic shock. What about respiratory insufficiency? Patient with a severe chest injury may be unable to breathe, right? Either some type of crushing thing, a blow to the chest, some type of blunt trauma. It's hard for me to take a breath. Oh my gosh, what's going on? I can't take in the adequate oxygen necessary to survive. An insufficient concentration of oxygen in the blood can produce a life-threatening situation as rapidly as vascular causes of shock. So same thing, just as bad as circulatory system starts to fail, that respiratory system can be just as bad. Anemia, for someone being maybe anemic, abnormally low number of red blood cells. Anemia may be the result of either chronic or acute bleeding, deficiency in certain vitamins or minerals, or an underlying disease process. Hypoxia, right? Low levels of oxygen in that bloodstream occurs because the blood is unable to deliver adequate amounts of oxygen to the tissues, all the way down to the cell beds. It's not there, right? Hypoxia is a bad thing, just like we talked about hypercarbic, that would be too much carbon dioxide in the blood. So now I have not enough oxygen. In that same situation, I may have too much CO2 also, because I can't get rid of it either. Certain types of poisoning may affect the ability of the cells to metabolize or carry that oxygen. You get like a carbon monoxide poisoning. Carbon monoxide poisoning combined to the hemoglobins much more effectively than an oxygen molecule would. Therefore, it's going to be transporting around carbon monoxide instead of oxygen, right? You get that late sign of red flushed look in the face. Cyanide poisoning, okay? That would be another example, as it binds to the hemoglobin and transports the cyanide instead of taking the oxygen where it should go. Some of the how do we progress for shock now? We mentioned about body and how it compensates, right? So with compensated shock, early stages when the body can still compensate for that blood loss. Heart rate increasing, respiratory rate increasing, my ultramental status starts to change slightly, right? My body is trying to compensate for this. If I'm bleeding, it wants to try to do the clotting process even. If it's something because I'm dehydrated from diarrhea, vomiting and stuff, my body will eventually get rid of all that and hopefully stop doing that and try to compensate for it and recover from that, right? So anaphylactic reaction, again, a little more different where I may need some medication for that, but still, your body will try to compensate early on. Eventually, the body gets a little tired. It just wants to give up. I can't do it. I can't fight for myself here. I need something, right? Some medication on board, get me to the hospital, whatever, because eventually the body will start to decompensate. So decompensated shock is the late stage when the blood pressure starts to fall. It's one late sign. You'll see the blood pressure dropping. Okay? As that blood pressure dropping, eventually it's going to drop down to zero, if you will, right? No way to assess when the effects are irreversible, because that would basically be a third stage, is irreversible shock. It's not going to get reversed, right? This patient is really getting close to deteriorating and eventually dying. So you got to recognize these signs of shock and jump on it, right? Treat for shock aggressively. So again, some signs and symptoms here, just picture people going through some type of event, some traumatic medical condition where they're really freaking out, they're feeling like they're going to die, the anxiety of it, the respiratory pulse rates increasing, they're sweating, whatever it may be, and then eventually their mental status changes, their blood pressure drops, their things start shutting down eventually, and then goes into decompensated shock and eventually dies. So we mentioned blood pressure, usually a late or last measurable factor that we can check. When it drops in blood pressure is evident, then shock is you're behind the eight ball, well developed there. Now it would be tough as you respond to somebody who has a low blood pressure to begin with because of some chronic medical condition they may have. We really don't know what their initial baseline was or what their blood pressure was when they were healthy. But either way, we capture blood pressure and it's under 100 systolically, maybe like 90 over 40, example will be, they may already be behind that eight ball, right? And you're kind of chasing that patient. Particularly true in infants and children, and expect shock in many emergency medical situations, and of course, trauma situations also we can expect shock. That index of suspicion, right? So we can expect shock, multiple severe fractures, because we're thinking of significant blood loss, abdominal or chest injuries, core areas, a lot of blood volume, right? Spinal injuries, especially when we talk about neurological complications, severe infection, septic issues, major heart attack, and even anaphylaxis, type of, again, distributor shock, right? So we approach the scene, making sure as we approach the scene, proper PPE, gloves, eye protection, some type of mask, obviously, especially if there's significant blood loss or a really bad illness that we don't want things to be spreading around, of course. Potential hazards on the scene, making sure fire, explosions, active shooters, whatever may be the hazards, we want to make sure those hazards are mitigated before we actually gain access and make contact with our patient or customer. Again, proper PPE and in incidents involving violence, make sure the police are on scene, fire department for fires, hazmat team for the hazmats. You get the idea, right? Call the appropriate resources if necessary. So make sure everything was safe, worn our proper PPE, receive the consent necessary to start managing and assessing our patient. So let's start with this primary assessment, right? That general impression as we approach, again, I know ideally we want to see this from a distance before we make that initial contact, but to see, are they sitting up talking, complaining, breathing, living, are they slumped over this, or, don't look like they're breathing at all, they're blue looking, or whatever it may be, right? That general impression from a distance. The LOC, so now we've gotten the consent though, right? What's their level of consciousness? Using AVPU, right? Are they alert? Hey, I'm over here. Or, hey, sir, what, right? I'm alert to verbal stimuli. Or, sir, what? And I'm alert to painful stimuli, right? Or you pinch and pinch and pinch and pinch, sir, and I don't wake up whatsoever. I'm unconscious and responsive, right? And then get a baseline for that GCS, the Glasgow Coma Scale, right? 15 being the most, 3 being the worst, right? We got to figure out what that GCS is in conjunction with using the AFP. Rapid body scan, right? We can do a rapid blood sweep, alternating our hands, as we sweep down the areas that we cannot physically see. We obviously may have to remove clothing to perform this rapid exam. We want to make sure we do so we don't miss a life threat that we have to manage right away. Any of that, right? Find the life threats, manage the life threat right away. Excessive bleeding out of an extremity, slap on a tourniquet. We have air rushing out of a chest wall, cover it up. We got, something obvious with an airway issue, breathing issue, circulatory issue, significant burning, can stop the burning process, right? Cover them with something, right, to stop them from being on fire. Whatever the ABC type stuff is, including massive burns, those are life threats we got to deal with right away. Is there a need for C-spine? Do I got to direct my partner? Hey, partner, get over here. Hold the head in the inline neutral position and maintain that until we're getting ready to log roll this guy and put a collar on him, get him on the board and all that good stuff, right? Maintain it completely. Dealing with the airway, trying to make sure, is the airway even open? Is it like full of stuff? Is it full of blood, vomitus, whatever it may be? Are they able to open their own, keep their airway open, I should say? Are they able to maintain that patency of that airway? Or do we need to drop some type of an adjunct in their airway to help them keep it open? Are they even breathing, right? We gotta look for the breathing. We gotta look for the chest rise. We gotta listen for the breathing, right? We gotta listen to those lung sounds. And we gotta get the number, right? How much are they breathing? Let's get the rate, rhythm, and quality of that breathing, okay? And then we gotta act on this because that could be one of the life threats. We may have to give them oxygenation right away. We may have to be giving them positive pressure ventilation. We have to be giving them just a non-rebreather at 10 to 15 liters a minute. Maybe just giving them nasal cannula, something because the patient's conscious and a traumatic event with somebody dropping something on their foot or stubbing the toe, who knows. Increased respiratory rate, we would expect that when they are going into shock, right? And their body starts to compensate for it. Assess circulatory status, right? Is the person unconscious? We may have to go straight for that carotid, maybe even the femoral, right? If the person's conscious, we can try to go for distal pulse, of course. For hypoperfusion, treat aggressively. We're going to talk about the treating when we treat for shock. 5 big things you want to consider treating for shock. We also mentioned with rapid respirations, we know that the rapid pulse rate also from the patient compensating for shock. The skin may become cool, clammy, maybe even ashen. So what the body is doing, again, is drawing blood away from the skin. It's one of these organs we don't need right now, right? Just like we don't need the digestive system, reproductive system, right? It's going to start pulling blood from those areas and getting it up to the brain, the heart, and the lungs. Is this going to be a priority patient? Do we need ALS backup, right? Maybe they need some IV fluids. They need cardiac monitor. They need some type of medications that the medic can provide that we can't. And then, of course, which hospital are we going to? Are we going right to a trauma center? Can another hospital take them that's closer and they can at least keep the patient, to a certain point before they get transferred to that trauma center? We got to make that decision, right? Again, we talked about trauma patients, depending on the level of condition of the hospital itself. Is it a level 1 trauma center? Or again, can they sustain that patient, get them to a point where they can eventually transfer to an actual level 1 trauma center? We just got to know those in our response area and how we respond to other hospitals, which one's the closest, which one's a trauma center, which one's a burn center, so forth. So if they're, of course, awake and able to answer questions, maybe there's even possibly some loved ones that are there, coworkers, whatever. So we have to get some kind of a history from this patient or about the patient from someone else, okay? What was the chief complaint? Is the chief complaint, as you're transporting now, is the chief complaint still there? Have we not fixed this chief complaint, right? And get into your sample history, right? Sample history being the signs and symptoms, allergies, the medications, past pertinent medical history, surgeries, medical conditions, diagnoses, last oral intake, but also last output, right? If they're vomiting, if they're doing diarrhea, or they're just normal bowel movements, urinary output, and so forth, right? And then event for the, of course, events leading up to this condition. What was the cause of this? So again, with the secondary assessment, begins by repeating the primary assessment. Go into those vitals again. Go into the chief complaint. Again, are they still complaining about it? How is the airway, breathing, and circulation? oh, wow, this person started breathing again on their own. So we don't have to give them a bag valve mask now. Now we can start coaching this guy because they're awake and they're breathing on their own. We can give them a non-rebreather mask. So repeat that primary assessment, and it's going to be eventually followed by a focus assessment. Focus in on the problem, focus on the location of the patient's body, focus in on the gastrointestinal, abdominal area, maybe it's the head, whatever it may be, you got to focus in on that area. Performing the assessment of the body if there's trauma, right? We still got to go through the whole entire body system, systemically, right, or methodically, and going through in a systematic approach, I should say. There was a poor general impression, right? So we should be going over and doing a full assessment. You found problems in the primary assessment that would lead you to want to check, again, the rest of the body, performing a full assessment. And then medical problems, but the patient isn't responsive, so we still got to go in there and see. They may have a bracelet identification tag or something like that, but it may be another underlying issue. Someone can still have a medical emergency with a traumatic emergency at the same time. Right? I had a diabetic episode, I stumbled and fell down the stairs and I hit my head, okay? Treat for those life threats like we may have missed possibly, but again, don't want to miss them by the time we get them transferred over to a hospital, right? So find all those life threats and treat them right away. Get a complete baseline set of vitals and repeat, trend the vitals. Unstable people, every 5 minutes or so, maybe more. And if they're stable, they're communicating with you and so forth, you can go 15 minutes before you get that next set of vitals. Always monitoring that patient. It doesn't have to be physically assessing a set of vitals. Monitor them, talk with them. Don't put your face in front of that little tablet computer thing as you're doing your PCR in the back of the ambulance. Continue with that relationship with that patient, making them feel comfortable. And then use those monitoring devices, right? All the different types of monitoring devices helping with your vitals, okay? So, SpO2 monitoring, glucose, getting the blood sugar monitoring and stuff like that, right? And then reassess, kind of mentioned how often we should do it. Reassess the vitals, interventions. You put on a Band-Aid, for an example, just a generic term, a Band-Aid. Band-Aids tend to fall off. So make sure the Band-Aid is still there, still stuck, as an example, right? Do they still need that same amount of oxygen? When you manage their chest injury, do you need to still remanage it, if you will, and reassess that, making sure there may be an intervention I have to do. That'll be covered more with chest injuries, right? If they vomited earlier and you had to help them or suction their airway, could they vomit again later, right? So always reinvestigate, reassess these types of things. Their chief complaint, like I said earlier, do you still have that chief complaint? You're still complaining about that chest pain? You're still complaining about that, that bleeding? Are you still bleeding? Obviously, did we not control it yet? Their ABCs and their mental status, of course. Always reassessing these. Determine what interventions, again, are needed and what needs to be repeated. Focused on supporting the cardiovascular system, respiratory system, of course. Treat aggressively for shock. So we've managed the injury. We've given them some type of oxygenation. We've made sure, we're transporting them, but in doing so, we had to position them on a stretcher in a comfortable way, or maybe even shock position, depending on the type of injury they had. And then one thing we just haven't mentioned yet, I don't think, was talking about that thermal management, okay? So making sure we maintain that good thermal management. Since we start to compensate going into shock, we may not be able to regulate adequately body temperature, okay? So we start to shiver, it's 110 outside. So again, manage the injury, oxygenation, proper positioning, thermal management, and let's get them to that hospital right away. As soon as you recognize shock, begin the treatments, right? Standard precautions, PPE, control just life threats, okay? Period. Control and manage those life threats. Make sure the airway is clear, breathing is adequate, circulatory efforts is present, and they're not circulating outside their body, right? Maintain the head in an inline neutral position, possibly have to immobilize that patient onto a spine board or a backboard. Again, for positioning, comfort, and then, like I mentioned, thermal management, but comfort, calm, reassure. We don't want to lie to the patients. Oh, you're going to be fine. We don't want to say that. We're doing the best we can. Stay talking to me and stuff. Keep communicating with me. How's it feeling now? How is this working? Or whatever kind of questions you want to come up with, what's relevant to that patient's condition. But just a calm voice, Never allow the patient to eat or drink anything. They're going to feel like they're thirsty, right? We're going to mark thirst, right? Because of that traumatic event, the body's compensating. It's drawing blood, so I don't need to worry about my GI system and stuff. So when I start getting thirsty, real cotton mouth like, right? But I cannot give them something to drink because it may induce vomiting and stuff. So there's a possibility you maybe get some, sterile water and some gauze. They can maybe set up some gauze, but you really got to follow your protocols for that. Honestly, if there's a chance that they could just regurgitate or vomit because of something you stimulated them to do because you gave them something to drink, that would be a bad thing. So let's just keep it nothing per oral airway until they get to the hospital and let them decide. If a spinal mobilization is indicated, splint the patient onto that backboard. Pad those voids. It's not going to be very comfortable. They're hard devices. They're very flat. Obviously, and our bodies are not built flat, so we have a lot of contours. So make sure you pad those voids. Okay, very, very important. Proper oxygenation, proper positioning, thermal management. Let's get them going. So we kind of already said it though. Emergency care for shock. As soon as you recognize it, start your treatment. So you found life threat, you dealt with the life threat. You checked their airway, breathing, and circulatory efforts. You gave them proper oxygenation, of course. We make sure we're going to transport this person because we decide they're a priority patient based on a variety of things, their GCS, their condition, their traumatic event, right? Level 1 trauma, whatever it may be. So, or significant burns. So we make sure we're positioning them, give them some of that thermal management, of course, get them transported to the hospital, right? So manage that injury, give them some oxygenation, position them, thermal management, get them to the hospital. Can't stop repeating myself, okay? Very, very important. Patients cannot generate the power to pump the blood throughout the circulatory system. We mentioned this because this is, again, repeating about what we're going to do now to treat cardiogenic shock. So because it can't do that, that chronic lung disease can aggravate cardiogenic shock, and the patient in cardiogenic shock should not receive nitroglycerin. Their blood pressure is already dropping, going into shock. Once it gets below that 100 systolic number, if they took their own nitro, we can only assist with nitro. We can administer aspirin as a medication. We wouldn't do that either. I'm just saying for nitroglycerin, they should not take another hit of their nitro because you're going to drop into shock that much faster or quicker. Their blood pressure is going to bottom out. So don't take any more nitro. If you've already taken it, stop, stop, stop. And we are not going to introduce any aspirin either. Again, for treating with cardiogenic, they have low blood pressure, weak irregular pulses, starting to turn blue. We've already mentioned this, but the blood pooling to these core organs, anxious, they may be nauseated or vomiting already, right? They're freaking out. I think I'm going to die. So position that eases the breathing. If they feel comfortable laying on the back, then put them on their back. If they feel comfortable sitting up, then sit them up. Okay, whatever their position of comfort is, we got to put them in that position of comfort. When they're going in shock, right, and they're already to a point where they're unconscious, unresponsive, very altered mental status, we may be lowering their head down, and depending on their condition, just leaving them flat and getting ready for this condition to possibly get worse if we don't intervene quickly and aggressively. Again, assisting with ventilations. If they're not breathing well on their own, they can't breathe at all, we got to make sure we do positive pressure ventilations as quickly as possible with the proper oxygenation. Get them transported, of course. Consider ALS, mentioned that earlier, right? Calm reassurance to the patient. If they're alert, they can understand you, keep them calm, reassurance, okay? Don't lie. What about obstructive shock, right? Treating this. Cardiac tamponade, again, this is increasing cardiac output. It's going to be the priority, and this has to be done at a hospital setting. We still do shock management, but we're not going to go in there and try to fix their cardiac tamponade, right? Get them the oxygenation and get into that definitive care at the hospital. Tension pneumothorax, now again, oxygenation, a chest decompression is required, and ALS on scene can do this with a needle decompression. Okay, so they have that ability to do so, where they can relieve that pressure by sticking a needle in their chest to relieve that and allow that patient to start breathing better. Okay? That's an ALS skill, not a BLS. Septic issues, again, they need to get to the hospital. They need antibiotics, right? They need to get healthy again so their body rids that waste product, that infection, if you will. Same precautions as we do with anybody, of course. Same type of oxygen, just basically the oxygen that's appropriate and titrate appropriately. Whatever ventilatory support we need to do, thermal management that we need to do, positioning that we need to do, let's get them to a hospital. Specifically, we can actually tell them that we have a septic patient that we're treating aggressively with shock management, and they can get a sepsis team ready for you as you approach, and that can just save some time once they get to the hospital. Treating neurogenic shock. For the spinal cord injury patient, we may have to understand that their central nervous system is being affected, right? We're concerned about neck, head and neck injuries. We're thinking about mobilization, of course. So let's get them to that hospital right away. They're going to be there for quite a bit of time. There may be some bleeding in the brain, swelling in the brain, whatever it may be. We got to get them there, right? So same shock management. There just may require some immobilization in addition. Again, airway, spinal mobilization, assist with ventilations if necessary. I conserve body heat by giving thermal management. I like how we just worded it a little differently with each slide here. Ensure the most effective circulation, so make sure they are circulating. We don't need to intervene by doing CPR, right? Because that may happen eventually, and get them transported. Now, anaphylactic shock. So far, we haven't mentioned much about medication administration by us. Like, can we do something else besides simple oxygenation? Find the problem, oxygenation, position them right, get them a little blankie, let's get them to the hospital. Is there any type of medication we can help at some point? Here we can do administration of epinephrine. So with special training required at the hospital, once you get out in the field, that department you're with will say, yeah, you bet. Our hospital says EMTs can do epinephrine through an auto-injector, intramuscular, okay? So there may be a necessary treatment that we can do, or we can intervene with an epinephrine pen. Now, those people that you may run on that have this anaphylactic condition, if you will, they get bee allergies, whatever it may be, they may already carry their own epinephrine pens, and by the time you got there, they may have already self-administered. Cool, that's totally fine, right? But be prepared for you having to administer another one being one of yours, possibly, okay? That's definitely a possibility that someone can go into a reaction again, because an epinephrine pen is not a cure. Right? I'm not saying, aha, here's your epinephrine pen, now you're no longer allergic to bees, okay? That's not the case. All it's going to do is dilate the bronchioles, open them up, constrict the blood vessels. Remember, anaphylactic, I believe, was distributive type of shock. It's going to widen those blood vessels. So this is going to, the epinephrine is going to constrict those blood vessels and open up the bronchioles so they can breathe better and perfuse better. All right, get them transport, of course, oxygenation. A mild reaction may worsen suddenly. And yes, there are some points where when people are having respiratory problems, another skill with the EMTs, with the hospital training, you can administer albuterol. It's like a small volume nebulizer. So that could be something you could start early on, and then, oh no, they're always getting closed off, and we've investigated more that they were stung by a bee, and we found a bee sting or something like that. Then you may have to introduce your epinephrine auto-injector. Right? So it can progress. You may start out with albuterol medication to an epinephrine medication. So again, all else fails too, don't be afraid to call for help and call ALS. So psychogenic treatment, in an uncomplicated case of fainting, once the patient collapses, circulation to brain kind of recovers, right? So if I'm feeling faint now, by the time I go from this position to this position, the blood can easily get back to my head. And then I might sit up again and say, wow, what happened? Did I just pass out? Concern was you went from this position to this position, which means you may have hit your head, and we may have some underlying traumatic injuries because of this. So psychogenic shock can worsen other types of shock, you bet. I'm freaking out because of my heavy bleeding, which I'd be going into shock for that, and now I'm adding psychogenic shock to the situation. And again, like I said, because of traumatic events, look for some other injuries that may have occurred because of the psychogenic shock causing some type of slip, trip, or fall. If the patient reports being unable to walk after the fall, I got numbness and tingling in my legs or feet or something like that, I just can't get up and move around as well as I was earlier, then transport them, of course, record the initial observations, try to learn from other bystanders, did you witness this? Because the patient themselves says, I don't remember what happened. I was standing, woke up on the ground. No idea what happened, right? Bystanders, coworkers, loved ones, whatever, try to figure out what actually happened, what do they remember from their event, what they saw from their event. If the patient complained of anything, how long were they unconscious for? Were they breathing while they were unconscious? Did they seize while they were unconscious? Right? Try to ask all those kind of questions to the bystanders, or of course, the patient themselves if they recall. About treating hypovolemic shock, okay? Control any obvious blood loss. I know which is more of a hemorrhagic issue, right? Thermal management, oxygenation, proper positioning. But again, we want to make sure we're maintaining the ABCs and getting them to the hospital right away. ALS would also be a benefit too, because even if it's hemorrhagic or non-hemorrhagic, They might be able to do some fluid replacement, right? So that might be a good idea. They may not be carrying blood on the ambulances to replace blood loss, but they can do IV fluids, which will at least buy them some time. How about respiratory insufficiency, right? We're thinking of, there's a problem with the respiratory system, we're gonna give them some breathing, right? We're making do some oxygenation, right? To help them with some positive pressure ventilations possibly, right? Making sure the airway is clear though. We don't need to do any suctioning or add any adjuncts necessary. If they're unconscious and responsive, the adjuncts we use may even be an advanced type of airway that EMTs can do with special training required through the hospital, that we can do blind insertion. So there may be like a King airway or an iGel, whatever the examples are, that may be provided for EMTs to be able to do. If not, and you don't have that ability to administer those type of innovations, then you can get an ALS provider to show up and then they can do an advanced airway with their endotracheal intubation. So there may be a need for advanced airways. All right, so what about the older patients? Almost done here, guys. The EMT must use caution when caring for older patients. Talk about more of this when it comes to geriatric emergencies, but still, older patients, there are some specific conditions that older people tend to have from just time, right? Chronic issues. Eventually, the body starts breaking down. Older patients, more serious complications than younger ones. A simple fall from a low height may be more significant on an older person than it is a younger person. Illness is not just part of aging, so they may have, again, chronic or acute conditions from medical emergencies that may happen from other, smoking issues, the environmental conditions, their work, from years and years and years of being alive. Eventually, their lifestyle can build up some complications in the sense of a medical emergency. Not just because, oh, you're 80 years old, you get a medical injury or a medical illness, right? Many older patients take medications. Some older people take none. Some take, polypharmacy, right? And they take tons and tons of medication. They have a whole gallon-sized Ziploc bag full of medications. Some of them don't even know what they're for. I have no medical problems, but I take all these meds. That's why I don't have any medical problems, right? So just realize that. You want to make sure that they're finding out that maybe because of the medications they are taking or not taking, maybe kind of mimicking signs of shock. Okay? So we got to be aware of that. C-spine if indicated, of course. And if not indicated, maintain the patient in a position of comfort like we did with anybody else, okay? Control the life threats like we do with everybody. Suction the airway if necessary, of course. Body temperature, right? We want to make sure we're not getting them to go into hypothermic issues. So maintain that good body temperature and get them to the appropriate facility, okay? So that's your chapter 12, shock management. Again, hopefully as you pause and take some notes throughout this lecture, you bring that to class, and for that first hour, we'll be covering over any Q&A basically, right? Maybe even going over some of the review questions at the end of these lectures, right? You guys have access to these same lectures, so please feel free to continue reviewing these lectures prior to class, going over the review questions, bringing your notes to class, so you have something to discuss for that first hour, okay? Thank you so much for your time, and we'll see you on the next one.